Okay. Hi, I'm Maya. This is our opioid versus non-opioid pain management poster. I'm going to start us off with the process, questioning, and project planning. So our P is our post-surgical patients. Our I is our opioid pain management. Our C is our non-opioid pain management. And then our O is our effect on pain perception. So what initially prompted us to do research on opioid versus non-opioid pain management was the growing impact of the opioid crisis in our society, which we learned about specifically in our pharmacology class. We found out that the opioid epidemic continues to affect people of all ages and backgrounds, and the numbers just continue to rise. I found a quote from the CDC that said the number of annual opioid overdose deaths remain more than 6 times higher than it was in 1999. All the way up until 2022. Now there is approximately 81,806 opioid overdose deaths. So this very large statistic highlights the urgency in addressing opioid use, particularly in areas where opioids are frequently prescribed, such as post-operative pain management. So just some background, post-operative pain management is a critical component of nursing compassionate and effective patient care. It directly influences patients' outcomes and recovery experiences. So traditionally, opioids have been the first-line choice for managing post-surgical pain for patients. But however, due to their well-known side effects such as nausea, constipation, respiratory depression, and the increasing issue of dependency and misuse, there has been a noticeable shift from the opioid pain management to alternative options. So our research was mainly motivated by a trend of the opioid misuse and patient dissatisfaction of care among post-surgical patients. So studies have shown that non-opioid pain medications not only manage pain effectively, but also result in fewer adverse effects compared to opioids. So specifically, patients receiving the non-opioid pain management expressed reduced rates of respiratory depression, nausea, sedation, and drug misuse. And so in the nursing practice, pain management is closely tied to nursing sensitive pain indicators such as accurate pain assessment, such as the PQRST method. It's a nurse's responsibility to do regular pain rating documentation before and after medication administration, and then carefully monitor our patients for adverse effects. So these measures are vital in ensuring quality patient care and patient safety. So the opioid versus non-opioid pain management directly impacts our nursing assessment. And then ultimately, the research aims to contribute to the growing body of large supporting evidence for the use of non-opioid pain options instead of the opioid analgesics for post-operative patients. So overall, organizations like the ANA, CDC have also been supportive in kind of shifting from our original first-line management of opioids to non-opioid pharmacological interventions. So yeah. And then we're going to go into our evidence portion.
Hi everyone, I'm Destiny, and today I'll be highlighting the key evidence that supports the implementation of non-opioid and multimodal pain management strategies for post-surgical patients. So we did a couple different research articles, one being a network meta-analysis by Carter and the other contributors in 2020. And this article found that IV meloxicam was the most effective non-opioid analgesic for post-operative patients. It showed a 98.8% effectiveness rate in hysterectomy patients and also helped reduce the need for opioids, which is a big step in minimizing the risk of dependence. Similarly, a meta-analysis by Dolman and his contributors back in 2023 found that medications like IV lidocaine, gabapentinoids, ketamine, and dexmedetomidine significantly reduced chronic post-surgical pain. Gabapentinoids reduced neuropathic pain by about 30%, and dexmedetomidine cut opioid use by up to 40%, which again highlights the effectiveness of these alternatives. And then a retrospective study by Nierenberg and contributors back in 2023 evaluated the alternatives to opioids, or the ALTO program. This program was shown to reduce opioid prescriptions at discharge from 59.6% down to 40.3%, showing real world success in shifting prescribing habits. Additionally, a quality improvement project by Dolman back in 2023, which is a non-research article, in an ambulatory setting found a 50% reduction in opioid use and a 35 decrease in reported pain scores by using multimodal pain protocols. And lastly, a literature review by Volkow and contributors back in 2021 focused more on opioid use disorder and highlighted the effectiveness of medication-assisted treatment. It showed a 60% reduction in opioid relapse and a 93% success rate in overdose reversal using naloxone. So across the literature, there were several gaps that were identified. These included a lack of long-term data on chronic pain prevention. There was limited drug-to-drug comparisons. There's also some inconsistent reporting on patient-reported pain outcomes, and also some barriers such as cost and access to these resources, especially in lower resource settings or lower income settings. But in conclusion, the evidence strongly supports the shift towards non-opioid and multimodal pain management in post-surgical care. These strategies not only reduce opioid use, but they also help improve patient outcomes and can help prevent long-term dependency on opioids. And while there are still some areas that need further research, the current findings make a strong case for adopting these practices in our everyday clinical settings.
Okay. My name's Ashley. I did the translation section. That's what I'll be going over. And on non-opioid pain management strategies for post-surgical patients and how they can effectively implement in clinical practice has been actually improved. So they have research has strongly supported the use of non-opioid alternatives for managing post-surgical pain. And studies by Carter and Dolman highlighted the effectiveness of medications like meloxicam, gabapentinoids, and ketamine and IV lidocaine in reducing both pain and the need for opioids post-surgical. And clinical guidelines and multiple observational studies also have further reinforced the value of multimodal opioid-sparing approaches in surgical recovery. And there's different recommendations based off of the research, so we could implement multimodal pain protocols that could prioritize non-opioid options such as the meloxicam, ketamine, and gabapentinoids. And this was supported by Carter and Dolman. And then we could also adopt structured programs like ALTO, Alternatives to Opioids, and ERAS, Enhanced Recovery After Surgery, to standardize care, reducing opioid reliance and improving recovery outcomes. And this was supported by Nierenberg and Charipova. And then we could also educate not only the patients, but clinical staff on non-opioid pain management strategies to ensure buy-in and safe, consistent use across care teams, and to also prevent any like opioid prescriptions that are not necessary. And then we could track key outcomes such as patient pain scores, opioid use, and satisfaction levels after implementation to evaluate effectiveness. And this was supported by Dolman. This is especially important just because I feel like all of the studies were supportive, except they did lack long-term evidence. So this would be a good thing to keep following up on. And then another one would be foster like collaboration between pharmacy, surgery, nursing, and pain management teams for safe and smooth rollout of these protocols, so there's no confusion or miscommunication resulting in any errors. So in summary, the evidence is pretty clear. Non-opioid multi-model pain management is both effective and essential in reducing opioid use and enhancing recovery for post-surgical patients. And by possibly implementing these recommendations, we could improve outcomes, reduce opioid-related risks, and provide safer evidence-based care.
Okay, so my name is Viviana, and I'm going to be going over our action plan. So our plan is to improve post-surgical pain management through the implementation of standardized multi-module protocols using non-opioid options like meloxicam, gabapentinoids, and ketamine. Our main goal is just to reduce opioid use without compromising patient comfort or satisfaction. This matters because evidence strongly supports modal pain strategies in surgical settings and non-opioid regimens that can significantly reduce opioid consumption while still providing effective pain control. Similarly, programs like ALTO and ERAs have shown to improve recovery outcomes and minimize opioid exposure. Our proposed action plan includes updating EHR order sets to reflect non-opioid protocols, delivering targeted staff education that includes clinical scenarios, enhancing preoperative patient education, and then tracking key outcomes such as pain scores, opioid use, and patient satisfaction. This initiative will involve a wide range of internal stakeholders such as nurses, surgical teams, pharmacists, pain specialists, clinical educators, IT informatic teams, and then hospital leadership. And then externally, we'd want to engage patients and families, accrediting bodies, researchers, and then peers through publications and conference presentations. The essential message that we want to communicate really includes non-opioid multi-module pain strategies that are evidence-based and do not sacrifice pain control, and then programs like ALTO, ERAs that demonstrate improved recovery outcomes. And then lastly, long-term success that depends on education, collaboration, and then ongoing data tracking. We are anticipating some barriers, one being staff resistance to change, but we'll address that with engaging trainings that are led by experienced clinical educators. Another that we're anticipating would be limited availability for some non-opioid medications. So we'd work together with our pharmacy to adjust inventory and streamlining ordering. And then lastly, maybe inconsistent communication that can slow progress. So we'll want to tackle that through interprofessional team meetings and shared digital communication platforms. Our plan to get this information out would be internally would be to use staff meetings, EHR alerts, printed visuals in back rooms, and then real-time outcome data dashboards. And then externally, we'd want to share this through conference posters, peer-reviewed publications, patient education resources that are distributed via hospital websites and clinics. In closing, this protocol reflects a shift towards safer evidence-based pain management with thoughtful implementation and strong collaboration. We can definitely make a meaningful difference in reducing opioid reliance and improving post-op recovery for our patients. Thank you.
So, in reflection of just like our time with this project, the exploration of the literature definitely deepened our group's overall understanding of non-opioid and multimodal pain management strategies in like post-surgical cares. And through like reviewing high-level evidence from like systematic reviews and real-world quality improvement initiatives, it helped our group gain a clear picture of how these alternatives like not only work to effectively manage pain, but also play an important role in reducing like opioid consumption and prescription and like the associated risks with opioids. Our group was definitely surprised by the strength of evidence supporting certain non-opioid interventions, such as like the IV meloxicam and gabapentinoids and such, to reduce like both pain and opioid reliance. And so these findings definitely highlighted the growing potential for medications to replace or complement opioids in standard post-op protocols. And we were also surprised that like long-term outcomes and data and direct comparisons between non-opioid drugs remain limited because we were hoping that we would see lots more long-term data to support our stance. And some of those barriers, such as cost and medication availability and inconsistent pain measurement tools across studies, were also some expected limitations that kind of reinforce the need for like more standardized approaches and broader implementation research. But honestly, the process definitely shifted our perspective on the issue. Initially, we viewed it as just like a primary like prescribing concern, with just only like medications being prescribed for pain management. And it's now better understood as like a multifaceted challenge involving like education, access, and systemic changes throughout all interdisciplinary act teams. And so the findings support the need for evidence-based, patient-centered protocols that definitely prioritize safety, effectiveness, and long-term outcomes in patient surgical recovery. All right, thank you, everyone.
Thank you.